Cholecystititis. Definition. Cholecystititis is inflammation of the gallbladder. Symptoms include right upper abdominal pain, nausea, vomiting, and occasionally fever. Cholecystitis is an inflammation of the gallbladder. It normally happens because a gallstone gets stuck at the opening of the gallbladder. It can lead to fever, pain, nausea, and severe complications. Cholecystitis is inflammation of the gallbladder that occurs most commonly because of an obstruction of the cystic duct by gallstones arising from the gallbladder, cholelitiasis. Statistics and incidences. Cholecystitis account for most patients requiring gallbladder surgery. Although not all occurrences of cholecystitis are related cholelitiasis, more than 90% of patients with acute cholecystitis have gallstones. The acute form is most common during middle age. The chronic form usually occurs among elderly patients. Classification. Acute calculous cholecystitis. Gallstones blocking the flow of bile account for 90% of cases of cholecystitis, acute calculous cholecystitis. Blockage of bile flow leads to thickening and buildup of bile causing an enlarged, red, and tense gallbladder. The gallbladder is initially sterile but often becomes infected by bacteria, predominantly E. coli, Klebsiella, Streptococcus, and Clostridium species. Inflammation can spread to the outer covering of the gallbladder and surrounding structures such as the diaphragm, causing referred right shoulder pain. Acute calculous cholecystitis. In calculous cholecystitis, no stone is in the biliary ducts. It accounts for 5–10% of all cases of cholecystitis and is associated with high morbidity and mortality rates. Calculous cholecystitis is typically seen in people who are hospitalized and critically ill. Males are more likely to develop acute cholecystitis following surgery in the absence of trauma. It is associated with many causes including vasculitis, chemotherapy, major trauma or burns. The presentation of calculous cholecystitis is similar to calculous cholecystitis. Patients are more likely to have yellowing of the skin, jaundice, than in calculous cholecystitis. Ultrasonography or computed tomography often shows an immobile, enlarged gallbladder. Treatment involves immediate antibiotics and colecistectomy within 24–72 hours. Chronic cholecystitis. Chronic cholecystitis occurs after repeated episodes of acute cholecystitis and is almost always due to gallstones. Chronic cholecystitis may be asymptomatic, may present as a more severe case of acute cholecystitis, or may lead to a number of complications such as gangrene, perforation, or fistula formation. Xanthogranulomatous cholecystitis, XGC, is a rare form of chronic cholecystitis which mimics gallbladder cancer although it is not cancerous. It was first reported in the medical literature in 1976 by McCoy and colleagues. Causes. The causes of cholecystitis include gallbladder stone. Cholecystitis is usually associated with gallstone impacted in the cystic duct. Bacteria. Bacteria plays a minor role in cholecystitis, however, secondary infection of bile occurs in approximately 50% of cases. Alterations in fluids and electrolytes. Calculous cholecystitis is speculated to be caused by alterations in fluids and electrolytes. Bile stasis. Bile stasis or the lack of gallbladder contraction also play a role in the development of cholecystitis. Pathophysiology. Clinical manifestations. Cholecystitis causes a series of signs and symptoms. Pain. Right upper quadrant pain occurs with cholecystitis. Pain spreads to back or below right shoulder blade. Leukocytosis. An increase in the WBC occurs because of the body's attempt to ward off pathogens. Palpable gallbladder. The gallbladder becomes edematous as infection progresses. Sepsis. Infection reaches the bloodstream and the body undergoes sepsis. Abdominal cramping and bloating. Fever. Chills. Nausea. Vomiting. Loose, light-colored stools. Jaundice, which is when skin and the whites of eyes turn yellow. Itching. Assessment and diagnostic findings. Studies used in the diagnosis of cholecystitis include history taking. Take a complete medical, surgical, personal, family, occupational and socio-economical history. Physical examination reveals the following: fever, tachycardia, and tenderness in the RUQ or epigastric region, often with guarding or rebound. Palpable gallbladder or fullness of the RUQ, 30% to 40% of patients. Jaundice, tilde 15% of patients. Biliary ultrasound reveals calculi, with gallbladder and or bile duct distension, frequently the initial diagnostic procedure. Oral cholecystography, OCG preferred method of visualizing general appearance and function of gallbladder, including presence of filling defects, structural defects, and or stone in ducts biliary tree. Endoscopic retrograde cholangiopancreatography, ERCP visualized biliary tree by cannulation of the common bile duct through the duodenum. Percutaneous transhepatic cholangiography, PTC fluoroscopic imaging distinguishes between gallbladder disease and cancer of the pancreas, when jaundice is present, supports the diagnosis of obstructive jaundice and reveals calculi in ducts. Cholecystograms, for chronic cholecystitis reveals stones in the biliary system. Note: contraindicated in acute cholecystitis because patient is too ill to take the dye by mouth. Non-nuclear CT scan may reveal gallbladder cysts, dilation of bile ducts, and distinguish between obstructive non-obstructive jaundice. Hepatobiliary, HIDA, PIPIDA, scan may be done to confirm diagnosis of cholecystitis, especially when barium studies are contraindicated. Scan may be combined with cholecystokinin injection to demonstrate abnormal gallbladder ejection. Abdominal X-ray films, multipositional radiopaque, calcified, gallstones present in 10%-15% of cases, calcification of the wall or enlargement of the gallbladder. Chest X-ray, rule out respiratory causes of referred pain. CBC, moderate leukocytosis, acute. Serum bilirubin and amylase, elevated. Serum liver enzymes, AST, ALT, ALP, LDH, slight elevation, alkaline phosphatase and 5-nucleotidase are markedly elevated in biliary obstruction. Prothrombin levels, reduced when obstruction to the flow of bile into the intestine decreases absorption of vitamin K. Ultrasonography, ultrasound is the preferred initial imaging test for the diagnosis of acute cholecystitis. Scintigraphy is the preferred alternative. CT scan is a secondary imaging test that can identify extrabiliary disorders and acute complications of cholecystitis. MRI, magnetic resonance imaging, is also a possible secondary choice for confirming a diagnosis of acute cholecystitis. Management may involve controlling the signs and symptoms and the inflammation of the gallbladder. Fasting. The patient may not be allowed to drink or eat at first in order to take the stress of the inflamed gallbladder, for fluids are prescribed to provide temporary food for the cells. Supportive medical care. This may include restoration of hemodynamic stability and antibiotic coverage for gram-negative enteric flora. Gallbladder stimulation. Daily stimulation of gallbladder contraction with 4-cholecystokinin may help prevent the formation of gallbladder sludge in patients receiving TPN. Pharmacologic therapy. The following medications may be useful in patients with cholecystitis. Antibiotic therapy. Levofloxacin and metronidazole for prophylactic antibiotic coverage against the most common organisms. Promethazine or prochlorperazine may control nausea and prevent fluid and electrolyte disorders. Oxycodone or acetaminophen may control inflammatory signs and symptoms and reduce pain. Surgical management. Because cholecystitis frequently recurs, most people with the condition eventually require gallbladder removal. Colecistectomy. Cholecystectomy is most commonly performed by using a laparoscope and removing the gallbladder. Endoscopic retrograde cholangiopancreatography, ERCP. ERCP visualized the biliary tree by cannulation of the common bile duct through the duodenum. Nursing management. Management of cholecystitis include the following: nursing assessment, integumentary system, assist skin and mucous membranes, circulatory system, assist peripheral pulses and capillary refill, bleeding, assist for unusual bleeding, oozing from injection sites, epistaxis, bleeding gums, petechiae, ecchymosis, hematemesis, or melena, gastrointestinal system, assist for abdominal distension, frequent belching, guarding, and reluctance to move. Nursing diagnosis. Based on the assessment data, the major nursing diagnosis for the patient may include acute pain related to the inflammatory process, risk for imbalanced nutrition related to self-imposed dietary restrictions and pain, nursing care planning and goals. The major goals for the patient include relieve pain and promote rest, maintain fluid and electrolyte balance, prevent complications, provide information about disease process, prognosis, and treatment needs. Nursing interventions. Treatment of cholecystitis depends on the severity of the condition and the presence or absence of complications. Pain assessment. Observe and document location, severity, 0 to 10 scale, and character of pain. Activity. Promote bed rest, allowing the patient to assume a position of comfort. Diversion. Encourage use of relaxation techniques, and provide diversional activities. Communication. Make time to listen and to maintain frequent contact with the patient. Calories. Calculate caloric intake to identify nutritional deficiencies or needs. Food planning. Consult the patient about likes and dislikes, foods that cause distress, and preferred meal schedules. Promote appetite. Provide a pleasant atmosphere at mealtime and remove noxious stimuli. Laboratory studies. Monitor laboratory studies, BUN, prealbumin, albumin, total protein, transferrin levels. Evaluation. Expected patient outcomes are pain relieved, homeostasis achieved, complications prevented minimized, disease process, prognosis, and therapeutic regimen understood. Complications. Cholecystitis can progress to gallbladder complications, such as pancreatitis, and inflammation of the pancreas, perforation of the gallbladder as a result of infection, enlarged gallbladder due to inflammation. Infection may cause the bile to build up. Cancer of the gallbladder, this is a rare, long-term complication. Death of gallbladder tissue, this can lead to a tear and ultimately a burst of the organ.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.